Today, I have two guests who will discuss the effect of cancer on bone health and vibration therapy on bone and cancer cells. It is a privilege to introduce you to two of the world's leading authorities on mechanical stimulation, cancer, and bone health. Dr. Gabriel Pagnotti received his Bachelor's of Electrical Engineering and his Master's and Doctorate in Biomedical Engineering, with his graduate and postdoctorate research focused on biomechanics and its impact on the musculoskeletal system and cancer. In 2020, Dr. Pagnotti joined the Research Division of Internal Medicine at the University of Texas MD Anderson Cancer Center as assistant professor along with Dr. Theresa Guise. Dr. Theresa Guise is a professor in the Department of Endocrine Neoplasia and Hormonal Disorders. Dr. Guise is chief of the Bone and Mineral Disorders section of the Research Division of Internal Medicine at the University of Texas MD Anderson Cancer Center. Her research has been instrumental in defining the role of tumor-bone cell interactions within the microenvironment of bones. Her work has had profound implications for treating bone metastases and associated muscle weaknesses. Dr. Guise has received multiple honors and awards for her contribution to bone research. She is the principal investigator in several grant research projects from the NIH, the Department of Defense, and the Cancer Prevention Research Institute of Texas. She has received continual funding from the NIH since 1992 and has published over 190 articles. Let's get to the interview. I bring you Dr. Guise and Dr. Pagnotti. Before we dive in to cancer and its effects on bone, could one of you please review what normal bone remodeling looks like for the viewers?
Thank you, Margaret. I'd be happy to do that. Bone is a hard tissue, but it's a dynamic tissue, and we often don't think about bone until it breaks. But there's a process that keeps bone healthy and strong, and we call that normal bone remodeling. And that involves several important components, which are illustrated on this diagram. It simplistically shows the bone microenvironment, as we like to call it, and the important cells and components of bone that are important for bone remodeling. There are three different cell types: the osteoclasts, which are large cells that destroy bone; the osteoblasts, which are large cells that form bone. Those cells secrete a protein that is deposited into the bone matrix. And when they make bone, they bury themselves in that bone and become osteocytes. Osteocytes are the mechanical sensors of the bone. They sense microfractures, they sense stress, and they send signals to the osteoclasts and the osteoblasts. And finally, the mineralized bone matrix, or the hard part of the bone, provides structure for the body, but it also stores growth factors in the body, which, as we'll talk about later, can stimulate cancer cells to grow. This process is going on in the body at all times. When there is a stress, the osteocyte can sense that and say there's a microfracture. It sends signals to the osteoclast to come in and remove that abnormal stressed bone. Then the osteoclast sends signals to the osteoblast to come in and form new bone over that area of bone destruction. That whole process keeps bone healthy, fresh, and strong throughout the body. And the whole cycle takes about 120 days in the body, and again, is occurring at all sites.
That was a really clear explanation. I really appreciate you going through in such detail, because I think it will be helpful now if you could explain how cancer cells impact this process.
Cancer cells can disrupt this normal bone remodeling process. They can do so when they get into the bone, like we show in this diagram here, or they can secrete factors that act on these bone cells, the osteoclasts and the osteoblasts, to disrupt the normal bone remodeling. When cancer cells get into this bone microenvironment, they secrete factors that can stimulate excessive bone destruction. And you can see here the increased number of osteoclasts on the bone surface, destroying the bone. They can also secrete factors that might stimulate the osteoblast to form abnormal, weak bone. When this abnormal bone destruction occurs, it causes the bone to weaken, and that predisposes to fracture. This is really important because when there's accelerated bone destruction and fracture, that increases the morbidity and the mortality of cancer patients. So it's very important to suppress this abnormal bone destruction. In essence, cancer cells hijack the normal bone cells to do their dirty work. So if a cancer, say a breast cancer or prostate cancer, spreads into the bone, like in this diagram, and makes factors that can stimulate bone destruction, then you get this accelerated bone destruction and fracture. The mineralized bone matrix, as I mentioned earlier, stores growth factors in the bone. So not only is the bone weaker and of poor quality, but those growth factors are released from the bone matrix when the osteoclast destroys bone. Those factors can feed back onto the cancer cells to stimulate growth, invasiveness, and production of more factors that stimulate the osteoclast. So in essence, it's like a feed-forward vicious cycle that promotes the tumor survival in the bone microenvironment. All in all, this is bad news for the patient because they have pain, fractures, they can have elevated blood calcium, hypercalcemia, or other catastrophic events due to this disruption of normal bone remodeling.
When you spoke about bone remodeling taking 120 days, the process that you're describing here, is it happening on a faster rate?
Yes, it accelerates the bone remodeling process so that there's so much bone destruction, the bone formation can't keep up. And that's one way that you lose bone. And that one way that you get poor quality bone, because there's less bone, the osteoblasts are trying to keep up, but they can't. So they form this abnormal bone, which is weaker. Cancer cells, when they get into the bone microenvironment, as I mentioned, disrupt the normal bone remodeling and cause these local effects in bone, fractures, pain, hypercalcemia, but they can also have abnormal consequences at organs outside of bone, i.e. they can have systemic effects. And one of the important systemic effects that cancer in bone can cause is muscle weakness. And how does it do that? Well, cancer cells stimulate these factors that stimulate the osteoclast, which I mentioned before, and a couple of the factors are shown here for your information, but there are many of them that can do this. When the osteoclast destroys bone, it releases growth factors that are stored in the bone matrix, like transforming growth factor beta or TGF-beta. There are accumulating data now to show that TGF-beta, when it's released from the mineralized bone matrix, can get into the circulation, go to different sites like muscle, heart, brain, and pancreas. But we know for sure that this causes muscle weakness. And it can cause muscle weakness even before we get severe muscle wasting like cachexia. This muscle weakness can predispose the patients to fall and have further fractures, which again will increase their suffering and mortality. So it's very important to block bone resorption, not just for the bone properties and stabilizing, making bones stronger, but also to improve the systemic effects that bone destruction might have, such as muscle weakness. We know that if we give drugs to block bone destruction, we can prevent this muscle weakness in mouse models. And we're planning to study this model in humans as well.
Very interesting. Thank you. Would you mind explaining how cancer treatment itself affects bones?
Cancer treatment probably affects bone more than cancer itself. And when we talk about cancer affecting bone, I was talking to you about cancer that has spread to bone, such as bone metastasis. But cancer treatment, even in the absence of cancer in bone, can abnormally affect bone. And this is likely true for most cancer treatments. We know that chemotherapy, radiation, which are commonly used in all types of cancer, anti-estrogen therapy, which is used in breast cancer, anti-androgen therapy, which is used in prostate cancer, and glucocorticoids or steroid hormones such as prednisone or dexamethasone that are used in many cancer treatment regimens have abnormal effects on bone to predispose for bone loss, fracture, and muscle weakness. These therapies directly stimulate the osteoclastic bone resorption to, again, accelerate that bone remodeling process in a way that the osteoclasts take over and destroy bone, and the osteoblasts can't keep up. So there's less bone formed. Some of these therapies, such as glucocorticoids, can directly inhibit osteoblast activity. The effects of these cancer treatments are profound, and some of these, like radiation, can cause profound bone loss in a short period of time. So it's really important to identify these before the treatments and prevent this bone loss by giving medications that could prevent bone loss or doing other therapies that could prevent bone loss.
And so in your research, did you use mechanical stimulation as one approach of preserving some of these cancer-associated bone losses?
Yes, we have. And Dr. Pagnotti will speak about the low-intensity vibration or the mechanical loading of the bone, how that works. We've used this in mouse models where we simulate breast cancer and breast cancer bone metastases. And in that setting, we make mice have estrogen deficiency. We remove their ovaries, we give them drugs to deplete estrogen. Those mice lose bone, they get muscle weakness, and they get fat. We've treated those mice with low-intensity vibration, as well as therapy to inhibit bone resorption, both separately and together, and both are effective. The combination of the two are better than either alone and seem to be a unique combination. So I think that mechanical stimulation of the skeleton with low-intensity vibration can have beneficial effects on these cancer therapy-induced bone loss situations.
So, Dr. Pagnotti, would you mind sharing how mechanical stimulation can affect bone? And we'll start with just healthy bone.
Low-intensity vibration, like exercise, is a form of mechanical stimulation. During the normal bone remodeling process of breaking down old bone and then forming new, healthier bone, mechanical stimulation triggers mesenchymal stem cells to multiply. It also causes these mesenchymal stem cells to form osteoblasts, which then go on to become osteocytes. And it's these two cells, the osteoblast and osteocyte, that are mechanosensitive cells in the marrow that are critical in the formation of new bone. So both cancer and cancer treatments, unfortunately, disrupt this process, and it makes it difficult to form new bone, which ends up reducing the quality of the existing bone and leads to muscle weakness down the line. The purpose of our research is to find and utilize non-pharmacological ways, such as low-intensity vibration, to reduce the negative effects that cancer and its treatments have on individuals' bones and muscles. To make matters worse, many patients with cancer and those being treated for cancer experience reduced physical activity, and this in and of itself can further impact bone and muscle health. So our research examined mechanical stimulation here in the form of low-intensity vibration as a possible candidate to counter the bone degradation from cancer. And what we found was that through mechanical stimulation, we were able to correct the imbalance in bone remodeling that's caused by cancer and its various cancer treatments. So it uses the skeleton as a natural conduit to deliver mechanical stimuli across the body as well as into the bone marrow space. And as a result, low-intensity vibration both increased bone formation as well as inhibited bone resorption. And this ultimately prevents the release of those bone and cancer-derived factors that make tumors grow further and damages the bone. So in addition to these already beneficial effects on bone, we've seen other benefits following the use of LIV, such as improvements in muscle function, as well as a reduction in the number of cancer cells and a reduction in the size of tumor or the amount of cancer that's seen throughout the body. So together, LIV has been shown to be safe and appears to provide many positive effects that can then be beneficial or advantageous for individuals with cancer.
Can one of you share how the mechanical signals can preserve cancer-associated bone loss in the clinic for individuals?
That's a great question. And it's an important question because many of our patients with cancer have bone pain or muscle weakness, so they can't do the usual weight-bearing exercise that we might prescribe for someone with run-of-the-mill osteoporosis. We've actually have a clinical trial at Indiana University where we're testing women who start treatment for breast cancer on low-intensity vibration. And we're testing their bone density, but we're also testing their muscle strength and doing muscle biopsies on those patients. There are, the way we're measuring bone quality in those patients is using something called an extreme CT because it's a three-dimensional measurement of bone. Previous studies have used DEXA, which is the standard test that we do to measure bone density, but it's a two-dimensional measurement, so it's not as sensitive as this CT, or computerized tomography, CAT scan. So we're doing very sensitive measurements in these women for their bone density over the course of a year using this extreme CT. There have been previous clinical studies in children with cancer, childhood cancer survivors who've used low-intensity vibration. It's been beneficial and resulted in a gain in bone density in those patients. So it seems to be a useful non-pharmacologic approach to help patients that can't exercise to load their skeletons. We're not proposing that this is an alternate treatment for the bone because we still prescribe bone-targeted drugs to prevent the bone loss. But we find in our models in the laboratory that if we add the low-intensity vibration to a standard bone drug like bisphosphonate or Zometa or a reclass that a patient might get for osteoporosis or bone metastases, that it adds to the benefit in bone quality. So both of the therapies together seem to be better than either one alone. So we think this is a great non-drug way to enhance the effects of our current therapies.
Well, that's very exciting. And may I ask how many minutes these individuals are on for the study? How many minutes they're using the platform?
So they're using it 10 minutes twice a day.
And is there a time period between the use?
Yes. So we recommend that they do have a at least several hours in between. So generally we recommend that they do it in the morning and in the evening.
Okay.
And so for our mice, we do it at the beginning of a morning shift and at the end of the day.
Okay, that's really helpful. And if you don't mind, I'm going to ask you a specific question because you're in the lab and seeing these things. And the last time I spoke to somebody in the lab seeing these things was Dr. Clinton Rubin, and he was speaking about the mechanosensory period, that's kind of dormant after. It's like we've had a big meal and it's like, oh, I don't need another meal for 3 to 5 hours. And our mesenchymal stem cells in the bone marrow, they feel the same way. They're like, oh, I had enough movement right now. I don't need it for a couple hours. Now, because he said 3 to 5 hours, I have so many clients that go, okay, is that my window? But you guys are like saying, beginning of the day, end of the day. So the window's a lot more generous. And I'm assuming you've sort of tested different windows, or you could get someone in the lab at the beginning of the day and get them back at the end of the day. So is it a practicality thing, or is it actual, evidence-based, I want to say?
I think much of what we do is based on practical applications in people and in mice. So we don't have the resources to do extreme time point measurements in mice or people to determine which window is most optimal. And I think those experiments are mostly done on cells. So our kind of interpretation of that is that a patient is probably getting benefit if they wait for 3 hours or 4 hours or even half a day. So I think doing it twice a day, and we don't really know what the best interval to do that is probably better than doing an extended period once a day.
So many women with breast cancer are prescribed aromatase inhibitors. So Dr. Guise, could you comment on the interaction between aromatase inhibitors and the low intensity vibration?
Yes, I have a lot of experience with aromatase inhibitors, both in the research lab as well as my personal use. They're commonly prescribed and they're the standard of care, the first choice in breast cancer treatment where the breast cancers have estrogen receptors. Aromatase inhibitors replaced another drug called tamoxifen, which was an estrogen receptor antagonist, which we still use, but clinical trials show that the aromatase inhibitors are more effective. And these drugs profoundly deplete estrogen. So they block an enzyme called aromatase, which converts both androgens that are produced from the ovaries and the adrenal glands. Androgens are converted to estrogens by aromatase. So aromatase inhibitors block that. And people who take aromatase inhibitors have extremely low estrogen levels, even lower than women who are in menopause. And that has been a very effective treatment for breast cancer. But it's also been subject of a lot of musculoskeletal problems in the women who take aromatase inhibitors. The most well-recognized effect is bone loss. Most women who take aromatase inhibitors will lose bone. And if they start off low, say in the osteopenia range, they will develop osteoporosis if it's not prevented. This bone loss is not prevented. So by blocking estrogen inhibits the bone-resorbing osteoclast. And by doing so, when you deplete estrogen, you get this accelerated bone loss again, and the osteoblasts can't keep up. So the remodeling is accelerated with the end result of bone loss. We know this causes fractures, and it can also have effects on muscle to cause muscle weakness women who take aromatase inhibitors get a lot of generalized aches and pains in their muscles, bones, and joints, which are ill-described but very common and may often result in women stopping the aromatase inhibitors. So we're always looking for good ways to help prevent those adverse effects. We use medications like denosumab or zoledronate or other bisphosphonates to prevent the bone loss associated with aromatase inhibitors, but it may not always restore bone to normal. So by using the low intensity vibration or mechanical loading of the skeleton, we're adding this non-pharmacologic adjunct to the therapy, because many of the women, because of the muscle weakness, aches, and pains, can't do the amount of loading exercise that they might do if they weren't taking these drugs. And again, as I mentioned before, the low intensity vibration can prevent the bone loss associated with aromatase inhibitors in our mouse models. It can also improve muscle strength in the mouse models and reduce fat. And Dr. Pagnotti's published preliminary results of this, and we're submitting this for final publication to, and it was this is the basis for a clinical trial that we're doing at Indiana University with Dr. Tara Ballinger, an oncologist, who is testing low intensity vibration on women who take aromatase inhibitors. So we'll know more information about that, but I think it's a very important tool for women who are taking aromatase inhibitors. There's also some subjective evidence that it may reduce the generalized musculoskeletal pains that these women experience. And I should say that I developed breast cancer a couple of years ago and have been taking an aromatase inhibitor. I've been treating myself like a little mouse. I have a low intensity vibration platform, which I use twice a day when I can, when I'm not traveling. And I've taken the aromatase inhibitor, and I've also taken zoledronate. Over the past year of that treatment, my bone density increased by 3%. So I was quite pleased with that result. And if I had just been taking the aromatase inhibitor alone, I would have likely lost bone. So I think it's a useful tool for our patients. It's not harmful in any way that we know, and I think it can improve the effects of other therapies.
You mentioned some of the other side effects of the aromatase inhibitors, like the aches and pains. Have you felt any difference with that for including the low intensity vibration into your life? Like when you're traveling, do you feel, I mean, I know you're sleeping in a different bed and everything, but do you feel any different,
Yes, I do. I do feel different. When I'm traveling, I always ache. My aches are worse. I always blame it on the travel, but I'm not doing my usual routine of my low intensity vibration. And I also do yoga as well for more mind-body integration. But I do feel when I'm not using it that I have more aches and pains.
Okay, thank you. Thank you for sharing your story. And I hope you're almost done your 5 years. You are going to be on this treatment protocol for 5 years.
Yes, for 5 years. So,
well, good. Yeah.
Sticking with it.
Yes. So that it's a motivation for women who are ready to not keep taking it, So, yeah. Well done. So, Dr. Guise, as a clinician and cancer survivor, and a user of low intensity vibration, do you recommend the use of LIV to all your clients?
I discuss the use of LIV with my patients in addition to their recommended bone-specific therapy, be it a bisphosphonate or denosumab. And I preface that by saying that this is not, the low-intensity vibration is not a substitute for another bone treatment that is FDA approved. Low-intensity vibration is not FDA approved to treat bone loss or osteoporosis. But I do share the data that we know from what limited clinical trials there are, as well as our mouse data. I share that with patients, but I also let them know that this is a research area. They can purchase the platforms and use them, and some of my patients have done that. And as I mentioned, I use a platform myself, as I am a breast cancer survivor and take, excuse me, take aromatase inhibitors. And I certainly respect the patient's decision to use or not use these devices. I just like to provide them with all the information that we have available, both FDA approved and adjunct therapy that I believe is safe, and maybe a safe addition to their current drug regimens.
Thank you. I'm going to put a plug in only because I live in Portugal. So in the EU, the low intensity vibration has been approved and recognized as a treatment approach for osteoporosis.
That's great.
For what it's worth.
Yeah. That is great. I'm so happy to hear that. I didn't know that.
Yeah, it's been several years actually. Yeah. I have another question because to me, I've never experienced cancer, and other than my husband's episode, which I know certain cancers I hear have a propensity to spread to bone, where the others don't. So do you, as a clinician, do you, sort of encourage people with certain cancers to consider low intensity vibration more than others that have a different cancer?
Well, that's a great question. And I encourage all the patients I see to consider it. Not just the ones where the cancer, it has a propensity to spread to bone, but also those that don't, because first of all, cancer, they're probably getting cancer treatment, which is going to adversely affect the bone. But also, in my experience at MD Anderson, where I see a lot of cancer patients, I'm always surprised at what cancers spread to bone that we didn't think spread to bone. It's just a matter of looking. But the common cancers that spread to bone are breast cancer, prostate cancer, lung cancer, kidney cancer, bladder cancer, thyroid cancer. And there's a primary blood-borne cancer called multiple myeloma, which arises in the bone marrow itself, which acts very much like bone metastases. It's similarly, the tumor cells stimulate osteoclasts to destroy bone, but it also causes the osteoblasts to stop forming bone. So it basically melts the bones away. So that's a very devastating type of malignant cancer to have in the bone. But many cancers can spread to bone. And we study many of them in the lab and study the mechanisms by which they interact in the bone microenvironment and how they co-opt the tumor, how the tumor cells co-opt the bone cells, and try to target those for treatment.
So this has been really helpful because the whole time I'm thinking, oh, it's really important for bone metastases, but in listening to the two of you, there's so much damage that the cancer cells themselves, before they even embed themselves into bone, between the cancer cells and then the treatment for those cancer cells that aren't even touching the bone yet, that can impact the skeleton. So if they're well enough, doing some mechanical stimulation in the form of exercise is so very critical. But if they're not well enough, having an alternative and it's great that you guys are researching this alternative for individuals with cancer as a viable way of keeping their skeletons safe and prolonging their lives.
We're very interested in engaging with our patients and educating them on these modalities, not just drugs, but alternative types of therapy, which can improve bone health. Because I think we mentioned in the beginning, we don't think about the bone until it fractures, but we want to prevent that fracture, because once you have that fracture, your risk for future fractures is higher. And also, if you have cancer, it can decrease your lifespan and cause really significant pain and suffering. So it's really important to prevent the bone loss and prevent the fractures. And I think the low intensity vibration is a great way to help us do that.
Super. Well, thank you very much. To learn more about cancer and bone health, go to my playlist here. Thank you for joining me today.